and he will present the work on those cyclosporine improved clinical outcomes in STEMI patients, the Circus Trial. Michel, please.
Thank you. Good morning. The presentation today is about the Circus study. Circus stands for Does Cyclosporine Improve Clinical Outcome in ST Elevation Myocardial Infarction Patients? This is my conflict of interest with neuropharmaceuticals. Basically, when a patient is doing an acute myocardial infarction, he suffers from two additional injuries. The injury that occurs during the occlusion of the artery, the ischemia injury, and second, the reperfusion injury, that is an additional injury that occurs after the artery has been treated and reopened. This is not treated in clinical practice. We have no treatment for that. And the mechanism is likely related to a dysfunction within the cells at the level of what we call mitochondria. And in this mitochondria, there is a pore, a channel, called the permeability transition pore, that is causing death when the artery is reopened. And we have a drug called cyclosporine that is usually used in transplanted patients, which has nothing to do with the subject today. But this drug is also preventing the opening of this channel at that time. So it may be used, at least in experimental preparation, to prevent reperfusion injury. This is why years ago we performed a phase 2, a small pilot trial, in which we showed in patients, in acute myocardial infarction patients, that when you inject cyclosporine immediately before reopening the artery by angioplasty, you can reduce infarct size measured by different techniques. So this was very encouraging, and we wanted to perform a larger study, a phase 3 study. This is the Circus study, the one we are talking about today, in which we wanted to go beyond infarct size reduction and see whether this injection of cyclosporine could improve clinical outcome in STEMI patients. So we had the primary endpoint for that study, and we followed up patient for 1 year, and the primary endpoint was a combined endpoint of all-cause mortality, worsening of heart failure during the initial hospitalization, or rehospitalization for heart failure within the first year, and what we call LV remodeling, which is a reshaping of the heart after acute myocardial infarction measured by echocardiography. And we performed that study in 42 centers in 3 countries, Belgium, Spain, and France. And as you see, the study started in 2011 and finished in 2015. We recruited 970 anterior infarct patients, very severe acute myocardial infarction patients, and the primary analysis was performed in approximately 400 patients in each group. And the final result is as follows. The primary endpoint on top of the slides, the combined endpoint of death, heart failure, and LV remodeling, shows that there is no difference between the two groups. That is, cyclosporine did not improve clinical outcome as measured by this primary endpoint. And below the table shows also, if you look at what we call secondary endpoint, that cyclosporine had no effect whatsoever on either cardiovascular death, heart failure, rehospitalization or worsening, cardiogenic shock, recurrent myocardial infarction, stroke, or anything else. So in conclusion, we can say that cyclosporine did not reduce the risk of the composite outpoint in the Circus study. Nevertheless, it is important to note that nearly 25% of patients, although optimally treated, still die or have severe heart failure during the first year after acute myocardial infarction. And this study does not challenge the concept of reperfusion injury, and there are others, pilot phase 2 trial that are encouraging using other drugs, and we hope that in the future we can tackle reperfusion injury in an efficient way. Thank you. I'm taking your question.
Thank you very much, Michel. And we have now, please, go ahead. Can we have a microphone, please?
Hi, I'm Peggy Peck. I'm with MedPage today, and just you mentioned at the end that there are other trials investigating other drugs.
Yeah.
And I'm just wondering if you could give a little bit more detail on what other drugs you're talking about.
Yeah, we recently, a couple of trials were presented the 2 or 3 years before. For example, there was a MetoCard trial with metoprolol, beta blockers. These are phase 2 trials showing that it can reduce infarct size and improve cardiac function in STEMI patients. There was also, by Greg Stone, by the way, abciximab, for example, an anticoagulant agent that injected in the coronary artery can also reduce infarct size. Exenatide also is a drug that can reduce infarct size in STEMI patients. So these are pilot trials, and we are waiting for the phase 3 trials to see whether they can improve clinical outcome. These are examples.
Please.
Hi. The editorial in the New England Journal hints that it might have been the formulation of cyclosporine rather than, the fact that it didn't work. I was just wondering what your thoughts were on that.
Yeah, that's true. That's a good question. We, in the pilot trial we published years ago, we used the commercially available form of cyclosporine by Novartis called Sandimmune. And there is the vehicle for cyclosporine in this drug is called Cremophor. And the drug we used in the Circus Trial is slightly different. The vehicle is a lipid emulsion, which is slightly different from Cremophor. So, of course, it's a fair question to ask whether this may have played a role in the difference between the two trials. We have tested in experimental model the current cycloemulsion, and we saw that it also reduces infarct size in experimental preparation. So, although it's a fair question, I don't think it played a role in this in the final result.
Please, madam.
Simone Reisdorf, Medscape, Germany. Do you have an explanation for the fact that cyclosporine did not improve the outcome? Another explanation?
Sorry, I didn't get your question.
Do you have an explanation for the failure of cyclosporine? For the outcome did not improve?
Oh, yeah. Yeah, that's an obvious question. There may be several explanations. One very difficult aspect of treating acute myocardial infarction and reperfusion injury is that the window for reaching the target is very narrow. We have to inject the drug before reperfusion. The damage to the heart occurs within the first minute of reperfusion. So there's a global pharmacokinetic issue. That is, we have the drug to be on board, active very quickly, and we never are sure that this is the case, in fact. So, and there are many confounding factors. There are many other drugs circulating in the blood in this patient that can modify the pharmacokinetics, etc. So this is one part of the explanation, possibly.
Madam on the front row, please.
Melissa Walton, Shirley with Heart.org. Any idea about maybe injecting this intra-arterial?
Yeah,
is there a vehicle for that, or?
Yeah, this is a good point. Injecting directly into the coronary artery would maybe a solution, but it is kind of tricky technically to do that on a daily basis. It can be done, of course, but we don't know also whether it would be efficient. We have never tested it in experimental preparation. We don't know the dose, but this is an open question. That's fair.
Any other questions?